Hi, my name is Dr. LaRusso. I'm a rheumatologist, and I'm here to talk to you today about the workup and diagnosis of inflammatory arthritis. Really what we're going to be talking about are just some blood tests that we order when evaluating a patient that we may think may have a systemic illness that's causing some of their joint pain. So the first blood test we're going to talk about is the ANA, or the anti-nuclear antibody. And all this is an autoantibody directed against a patient's nuclei. And as you can see, they're associated with very specific rheumatic diseases. In lupus, there's about a 99 to 100% positivity rate of an ANA with that disease. But also please note there's other diseases such as autoimmune thyroid disease, MS, primary pulmonary hypertension, and neoplasia, where you can have a positive ANA. And how is the ANA performed? Well, the gold standard way of doing the test is by an indirect immunofluorescent assay. So you have a slide at the bottom here, and you add permeated cells. We then add the patient's serum, and so we hope that the antibody from the patient's serum will attach to the nuclei. We then add a conjugated antibody that has fluorescein on it. We then measure the amount of fluorescein that we see in a microscope. And the amount of antibody that is present is directly associated with how much of a dilution. So we start out with a 1 to 40 dilution, and we keep increasing it 1 to 80, 1 to 160, 320, and so forth, and seeing how much can we dilute and still have that antibody present. So can a healthy person have a positive ANA? Can they be ANA positive? Yes, absolutely. And the lower the titer, the more likely you're to see a positive ANA that's not clinically significant. So as you can see here, an ANA of 1 to 40, which is a very low titer, you can see 2% to 30% of the population will have a positive ANA. As you get higher, about 1 to 160, it drops down to about 5%. So someone who has a healthy person with a relative who has lupus, we can see a positivity rate of up to 25%. And as we get older also, the rate of a positive ANA that's not clinically significant goes up as well. So who should we order an ANA on? Well, we get an ANA on someone that we have a high pretest probability. So someone that has systemic issues, if they're having fevers, weight loss, rash, sicca symptoms, Raynaud's, if it's a few joints that are hurting them, not just one joint, that's someone that we would order an ANA on. I would advise not to get an ANA on someone who has back pain or if it's just one joint that's hurting them. The next test we'll talk about is the ESR, or the erythrocyte sedimentation rate, and the gold standard way of measuring this is through the Westergren method. So what we have here is just a vertical tube, and we add anticoagulated blood to that tube. So what will happen is the red blood cells will settle to the bottom, and it'll leave the clear plasma on the top. We measure how much plasma we see that has separated out in 1 hour time, and that gives us our ESR. So the more proteins that are present, such as acute phase reactants, the faster those red blood cells will settle out and the higher the ESR will be. So this is an indirect method of measuring inflammation. So some causes of an elevated ESR, we have, of course, rheumatic disease, infection, malignancy, trauma, and tissue injury. But we also have non-inflammatory conditions as well. So pregnancy, diabetes, end-stage renal disease, the ESR can go up in female sex, and as we get older, and in obesity. So there's a simple adjustment to find out what the upper limit of an ESR should be based on age. So the lab will usually say a normal ESR is from 0 to 20, but we should adjust for age. And in women, we take age, we add 10 and divide by 2, and that's the upper limit of normal. For men, we just simply take their age and divide by 2. Next test we'll talk about is the C-Reactive Protein, and this is just a pentameric protein that's produced as an acute phase reactant by the liver. Elevation will occur within 4 hours of tissue injury, and it peaks within 24 to 27 hours. A normal value is less than 5 to about 1. And also be careful when ordering this test that you're ordering the regular CRP rather than the high sensitivity CRP. They're both the same test, but it's the normal value for a regular CRP is in milligram per deciliter, and a high sensitivity is milligrams per liter. So the numbers will be off a little bit, and if you're comparing two different values and one of them is a high sensitivity, it could be a little bit confusing. So looking at the ESR and the CRP, the ESR is an indirect measurement of inflammation rather than the CRP is a direct measurement of an acute phase reactant. ESR can be elevated in other conditions such as pregnancy, diabetes, end-stage renal disease, anemia, obesity, and hypergammaglobulinemia. CRP can be affected by race, age, and obesity. The ESR remains elevated for a longer period, so it decreases by 50% in 1 week, as opposed to the CRP starts to decrease. It has a half-life of 18 hours. The next test is the rheumatoid factor, and this is just an autoantibody directed against the Fc fragment of an IgG. So it's an antibody against another antibody, and the prototype is IgM. So some labs will separate an IgM, an IgG, an IgA, but the one that we mostly look at is an IgM. And this has a 60 to 80% sensitivity for rheumatoid arthritis, and it has about 80-92% specificity for rheumatoid arthritis. And it's important to note that the titer does not fluctuate due to disease activity. So when we have a patient with known rheumatoid arthritis, we don't follow the rheumatoid factor. We'll look at the ESR and the CRP, but if a rheumatoid factor is positive, we don't have to check it again. Also note that a rheumatoid factor can be seen in a normal, healthy individual at low titers, usually less than 50. And as you get older, you can have a positive rheumatoid factor that's not clinically significant. We can also see positive rheumatoid factor in things such as primary biliary cholangitis, idiopathic pulmonary fibrosis, Sjogren's, lupus, scleroderma, mixed connective tissue disease, neoplasms, infections, namely hepatitis C, and cryoglobulinemia. The next test that we order when assessing a patient for rheumatoid arthritis is the CCP, the Cyclic Citrillinated Peptide. And these are antibodies directed against the citrulline residue on proteins. So during inflammation, arginine residues can be converted into citrulline and therefore seen as an antigen by the immune system. This has a similar sensitivity to the rheumatoid factor, about 75%, but it's more specific for rheumatoid arthritis, about 90 to 95%. 10% of RA patients can be rheumatoid factor negative, but CCP positive. So I always advise if you're going to be getting a rheumatoid factor, get the CCP along with it. There's no reason not to get one without the other. Also note that up to 16% of patients with psoriatic arthritis can have a positive CCP. And the last test we'll discuss is the HLA-B27 genetic marker. And this is a human leukocyte antigen. And it's present in 80 to 95% of patients with ankylosing spondylitis. 6% of the general population can be HLA-B27 positive. And HLA-B27 is thought to play a role in the pathogenesis of ankylosing spondylitis, though it's not exactly clear what that role is. So consider ordering this test in a patient less than 45 years old with chronic inflammatory back pain. Thank you.